Hi, and thanks for taking the time to help us review this draft of a system map for the early detection of cardiac amyloidosis. My name is Lexis Koskin. I'm an assistant professor of population health at Arizona State University's College of Health Solutions, and I work on a team that's led by Dr. Sandesh Dev, who's a cardiologist and a researcher whose work largely focuses on increasing screening for the early detection of cardiac amyloidosis. To give you a little bit of background on the creation of this iteration of a map, because there have been quite a few iterations. In January of 2023, Dr. Dev helped organized a conference in Scottsdale at the Health Future Center, and it focused on cardiac amyloidosis. And after the team held a workshop that included both patients and providers to try to figure out what's going on when it comes to screening for this disease. And so we recorded the workshop led by Dr. Sherry Ball. We conducted a rapid qualitative analysis, and we started piecing together what we learned from that workshop into a more cohesive map for what happens when people get screened and what happens when people are not being screened for this potential underlying cause of a diverse array of symptoms. So I'll walk you through the map. We'll talk about what was not included in the map but might be included in future iterations and what are some of our next steps. So to begin, we started the map with the patient. We also decided to include the family because often the families might encourage a patient experiencing certain symptoms, hey, you really need to go get care, or especially if it's a hereditary form of cardiac amyloidosis, they might be hearing of some of these symptoms and it might, prompt them to say, hey, there was this disease, it's, so-and-so had it or I had it, and you might want to go get screened for for cardiac amyloidosis. And so the patient can come into the healthcare system with different clinical presentations. And the reason we wanted to include all of these clinical presentations is to show that this is not a clear-cut, the patient showed the symptoms, that made providers think, screen the patient for this, and it was this very easy path to treatment. Patients might be coming in for something that seems benign, such as carpal tunnel syndrome. They might have a bicep tendon rupture. They might be experiencing neuropathy, have spinal stenosis, or might actually show more like cardiac conditions such as atrial fibrillation, heart failure, the need for a pacemaker. And these are just some of the early red flags that maybe there's an underlying condition that the patient has that's leading to experiencing these symptoms. And so in some cases, especially with atrial fibrillation or heart failure or the need for a pacemaker, a cardiologist, a primary care provider might order an echocardiogram. And after that's been interpreted, might decide, okay, this patient really needs to be screened for cardiac amyloidosis using PYP screening. To take a step back, one thing I wanted to say about the providers in this initial clinical presentation box, this is not a fully exhaustive list. These were just some of the providers that we tend to think of who would treat these symptoms, and who might be seeing patients at an early stage and think, maybe I should screen them, or maybe they should be screened for cardiac amyloidosis. But again, not all of these symptoms really offset, like, it could be this condition, it could be this disease that's causing these symptoms. Okay, let's get back to the top track. So patients might receive the PYP screening, and it's reviewed by a cardiologist or primary care provider, and based on what they see in that screening, they might determine whether or not the patient needs to be treated for cardiac amyloidosis. On the other hand, there might be these, patients might be experiencing any of these symptoms, and the provider might diagnose and treat the symptom, but not look for an underlying cause. Because, again, providers, one thing that we learned in our workshop is that cardiac amyloidosis is seen as the zebra, not a horse, as a potentially rare condition, and so people might not be looking for this underlying condition, seeing that they view this as rare. So the patient's symptom might be treated, the patient might be treated, and then eventually over time might experience other symptoms and re-enter the healthcare system or come back for continued problems with that symptom. So barriers that are present throughout this entire navigation of the healthcare system include that we live, work in a complex healthcare system. And then also there's also the additional barrier of insurance. What will insurance pay for? What screening tests will they pay for? And what might take a little bit more negotiation or prompting from the provider for insurance to cover it, if they will cover it. So some of the implementation strategies, or rather, let's just use the term intervention, some of the interventions that were brought up during the workshop that could help overcome barriers include patient navigation. So I do want to mention that we are going to be asking for your feedback on this map, and we're going to be doing that via focus group interview, and if that's not feasible with your schedule, potentially email response. And so whether or not you believe patient navigation really begins as early as this screening, or whether it belongs beginning in the treatment for cardiac amyloidosis, that's something that we can discuss in an upcoming focus group or interview. Other interventions that might help reduce treating a symptom and not the underlying disease could be a patient take back. When a patient was treated for the symptom, but it turned out that they had cardiac amyloidosis, and a provider takes the opportunity to go through with another provider and conduct a patient take back to highlight, okay, well, it could have been this instead, or it was this instead. And there's also patient advocacy training, especially for those with a hereditary type of cardiac amyloidosis, and those who are considered at risk. So what's not included in this map include the role of centers of excellence, the role of pharmaceutical companies, especially when paying for provider trainings and offering fellowships to help providers learn a bit more about this disease, the role of professional societies who could offer patient advocacy and education, additional provider training, and policy and administrative guidance. Again, this is just a draft of our map, and we'd love to get your feedback to learn more about what looks right, what would you add, what would you edit, would you create additional steps, would you take out some steps, would you take out the names of the different types of providers, would you include more providers? These are things that we hope to have a conversation with you about in the near future to learn more about how to improve this, again, draft of a system map so that we can start in the future planning interventions, tailoring this to a healthcare system, and then planning interventions that will help increase screening of at-risk patients for cardiac amyloidosis. Again, thank you for your time, and we look forward to hearing from you soon.